What a kind introduction. Thank you very much. I'm so glad to be here. I love Boston. I grew up in Maine, north of here, surrounded by trees. In my childhood, Boston was the exciting place to come, and that's how I still think of it. It's still an intellectually exciting place to be, and many, many of my students, when they graduate, come here. I think all of them, the last 4 students I've had, are now here. So it's a pleasure to be here. As Menton said, I'm going to talk about computational medicine, and the Institute for Computational Medicine at Hopkins was started in 2005, and this is our working definition of computational medicine. We're always thinking about this and trying to massage it, but this is how we see it now. We do 3 things. The first is we develop computational models of disease. They could be mechanistic models. They could be statistical models. It depends on the application area, but modeling is the essence. And this is where faculty in the Institute connect most strongly to basic science. The second thing we do is we personalize these models using data from patients. We all know that models these days can be very complex. They can be highly parameterized. They can be very high dimensional. It's a very real and serious and challenging question of what can you actually measure in a patient that can be used to constrain such potentially complex models. And we're very limited in what we can really measure in a patient. And so that's part 2. Part 3 is now doing something about this, applying the models to do improved diagnosis and help treat patients more effectively. And it's these last 2 bullet points that connect strongly to the clinic, and I'm going to give you 3 examples of computational medicine today. And one thing I want to make sure I point out in these examples is the remarkable nature of the faculty that are doing this work and how motivated they are to take the hard step of really truly translating the modeling work that they do into the clinic. That's a very challenging thing. And if any of you are interested in our position paper on this topic, where we give even more examples, not just of our work, but work in the field, take a look at that position paper. I like this way of answering the question, why are models needed? It's really an idea that was put forth by my colleague Dennis Noble at Oxford University in his wonderful book, The Music of Life, which I recommend to you. And this is a figure from his book, and it just shows the multi-scale nature of biological systems. It captures the fundamental, well, the so-called central dogma of biology, that DNA flows from the level, information flows from the level of DNA upward in biological organization to organ systems, and organism. But it also captures the emerging fact that despite the fact that there is complexity at each of these levels, all the levels are interconnected with one another by not only the feed-forward pathways, but multiple feedback pathways, which we now know includes environment to cell, tissue, and DNA and RNA. And so Dennis likes to say that function, therefore, does not reside at any one of these levels. It is the collective behavior that emerges across all of these levels. And so due to this complexity, whether we are asking questions about fundamental biological function or about biological function in disease, mental models just don't suffice. These systems are far too complex for our intuition to be 100% reliable. And time again in my career of modeling, I have seen how my own intuition fails and how through careful development and analysis of a model, you get new insights that just break from your intuition and provide you some insight into how biology really works. And so we like to say that computational models are necessary to navigate the complex landscape of disease. This is who we are, and I want to show this slide to make clear the 4 areas that we work in, that we've carved out. Not to say that these are exhaustive, but these are our thrust areas of computational medicine. And so we work in an area called Computational Anatomical Medicine. This is a discipline that was really founded by Mike Miller. He and Ulf Grenander 20 years ago wrote a famous book called Pattern Theory, in which they laid out the mathematical theory of how to characterize shape and its variations. And Mike has gone on to apply that predominantly in the area of neuroscience, but also in studying heart function and other areas as well. And he's extremely committed, having built new theory. That's one of the remarkable things about Mike, is that he's doing computational medicine, but he built new mathematical theory. He applied it to study brain structures, and now he's completely committed to driving these applications into the clinic. Second area is computational physiological medicine, and we have a number of faculty working in different areas, such as heart disease, the systems biology of infectious disease, such as HIV, neuromuscular disorders, motor control problems, and a third area is computational molecular medicine, and finally computational healthcare. And the examples I'm going to give today are selected from computational anatomical medicine, physiological medicine, and healthcare. I think we have an outstanding faculty. These are the core faculty. We have a much bigger group of affiliated faculty of the Institute, but I really appreciate our core faculty because we're a tight-knit group. We are tight, we click, and we work together well, and it's I think a great environment. So I want to begin with this example from the work of my colleague Natalia Troyanova, and it's in the area of computational physical medicine, and the application area is model-guided cardiac ablation therapy. And so this is therapy designed to help patients who suffer from cardiac infarction, who are having recurrent, life-threatening arrhythmias that can't be controlled. And these patients are targeted to undergo ablation therapies, where the goal of the therapy is to go in the cardiac catheterization lab, induce arrhythmia in the patient's heart, and try and figure out where reentrant waves are emerging in that heart, and then go there and burn and destroy that tissue to try and stop that reentrant wave from emerging and to terminate the arrhythmia in the patient. These can be very long surgery. These can be 12-hour surgery. Large numbers of burns can be made in a patient's heart, creating the specter that the therapy itself is creating a substrate for anatomic reentry via these burns. And so the problem is as follows. The problem Natalia wants to solve is to take imaging data on the structure of a patient's heart who's going to undergo surgery. So these are gadolinium contrast-enhanced magnetic resonance images that provide geometric data on that patient's heart, and in particular delineate the area of the cardiac infarct. And that's what you see in these images. These are patients' heart, and the yellow zones are the labeled regions of infarct in these patients' heart. And so Natalia takes these anatomic data, maps into them kind of a generic representation of the fiber structure of a normal heart. Cardiac muscle cells are long, thin cells, strongly coupled with each other at the ends. And so the direction of fiber orientation is a very important factor in understanding electrical conduction in the heart. So this information is necessary in the models. So that's one thing that goes into the models. The second thing that goes into the models are kind of generic biophysical representations of the excitability of each region of tissue in the model. And these are very, very molecularly, subcellularly detailed descriptions of the mechanisms of excitability in cardiac myocytes. It's important to be clear here what is measured from the patient, what can't be measured, and therefore what the constraining data is. We can't measure any of the biophysical properties I just mentioned in a patient. So she uses generic models, models from basic science studies of how cardiac tissue is remodeled near the infarct zone, in the infarct zone, and away from it. The fiber structure can't yet be measured in an individual patient. So that's inferred from other data sets. The only thing that can be measured in an individual patient is the fundamental shape of the heart and the shape of that infarct zone. And so the core question here is geometry enough to help treat these patients? So what Natalia does is she takes this data from an individual patient, does simulations to try and predict from the way in which the model captures a propagation of electrical activity in that patient's heart, where in the border region of the infarct zone a burn should be made to terminate the arrhythmia. So that's the problem. She makes a computational prediction of where that burn should be. So what you're seeing here is an image of a real patient heart. Each one of those little dots is a site where a burn has been made. Lots of dots, lots of burns in this patient. Computationally, she predicted a region where you go and burn there. That's where the reentrant wave is emanating from. If you burn there, it will stop the arrhythmia in this patient. The burns that terminated in this patient, computation wasn't guiding the surgery yet. The terminating burns were these made here. 4 out of, I don't know, maybe 50 burns in that patient's heart were the key burns. So the goal is to make a precise prediction of where to go, guide a physician to go there and do that. So Natalia has shown that this works well in pig models of cardiac infarction. Clinical trials are underway now at not only at Hopkins, but at other sites, including University of Utah, to, in advance, collect these imaging data, make these predictions, inform the surgeon, and have them go to that site, burn it, and test the hypothesis that effectively terminates the arrhythmia. So I think the remarkable thing here is the scale of modeling, the multiple scales involved here. The fact that it appears that geometric data alone is sufficient to solve this problem. That's all we can measure in the patient. All this other stuff we can't measure, it's in the models, but the key thing seems to be geometry. It seems to rule the day, so to speak. It's remarkable that this is now moving forward into clinical application. Now to talk about the computational anatomy work of Mike Miller. And I mentioned this book, Pattern Theory, and the work that he did with Ulf Grenander. What that work led to was a theoretical and computational approach to building what they called anatomic atlases. I'm showing you some examples here. These are averaged representations of populations of brains. And so this subcortical volume atlas, for example, has been annotated by an expert to show where different brain regions are located. And the algorithm that they developed for doing this is called the Large Deformation Diffeomorphic Metric Mapping Algorithm. And so the way these atlasing and mapping technologies are applied is that a patient's brain is imaged. That brain is mapped onto an atlas using the Large Deformation Metric Mapping Algorithm. And the reason for mapping onto an atlas is that the atlas now constitutes a common coordinate system in which we can study that patient's brain relative to a population of brains. So we know the statistics of the mappings from patients, for example, with Alzheimer's disease. And so we can individual patients' mappings to those of the population of patients with Alzheimer's disease and ask the question, does this patient have Alzheimer's disease? To do this, they look at the fine scale anatomy of the hippocampus. The head of the hippocampus is shrunken in Alzheimer's disease. So it's one of the earliest biomarkers of Alzheimer's disease. So these are the kinds of things that Mike's team does. And they take these mappings and they do analyses like principal components analyses to understand, for example, the 3 different orthogonal major directions of deformation that are needed to take a patient's brain onto the atlas. And so they plot those 3 weights for those 3 coordinate directions in a 3-dimensional space, and they find that patients with different kinds of brain disorders are mapping into different regions of space, and therefore they can do statistical hypothesis testing. Give me a brain, I can map it, I can see where it lands in this shape space, and I can test the hypothesis that brain image came from a patient with early Alzheimer's disease or other cognitive disorders and neurodevelopmental disorders. And so the remarkable thing is that in addition to developing fundamental theory and translating that theory into application, all of this information is now going into information systems at Johns Hopkins Hospital. A physician can open up the electronic health record for their patient, click on a link, and they will be taken to displays like this. They will see their patient's dot and where it lands in this cloud, in this shape space cloud. And that and they can see the results of a statistical test that is, what's the probability that this patient has Alzheimer's or aphasia or ataxia or whatever. And it's just one more piece of information that neuroradiologists can now use at Hopkins in making a diagnosis. And the key thing is it's actually in the electronic health record and it's being delivered to clinicians on a large scale. I think that's remarkable. The third application I want to talk about is in the area of computational healthcare. It's early detection of septic shock. This is work that's being led by my extraordinary colleague, Sri Sarma. She's a control theorist from MIT and moved in her postdoctoral work into study of motor disorder and motor disease, and has expertise in not only control theory and stochastic control theory, but machine learning, and I'm privileged to work with her on this. The problem here is that sepsis is, as you all know, a very common and very serious system-wide infection that can lead to reduced blood pressure, reduced organ perfusion, organ failure, and death. Mortality in sepsis is high. The statistics vary depending on what study you look at. It's just high. And it's a major source of hospital deaths, a major source of hospital deaths. And a key fact here is that a number of studies have shown that for every hour after a patient enters septic shock, mortality increases substantially. It's been estimated to be as much as 8% per hour. So rapid diagnosis and treatment of sepsis can offer the possibility of saving lives. This statistic makes that clear. So this is the conceptual basis of the work we're doing. And the key difference between what we are doing and what some others have done is that we are not only looking at data about the patient from the electronic health record, but we are looking at the minute-to-minute vital signs data that are sent from the patient monitors and that we are capturing and using to understand the physiology of the patient. So the relevant vital signs data is here are things like blood pressure and ECG measurements and respiratory rate and other physiological functions. These patients are very heavily instrumented, and so every minute these vital signs data are, we capture them from hospital information systems and store them. We then take these data, both the minute-to-minute data and the EHR data, and every minute after having recorded the data, we ask the question, is this patient in sepsis or are they in septic shock? And the way we diagnose the clinical state of the patient is to use the current consensus definition of sepsis and septic shock, which is the sepsis 3 definition, and depends on information in these minute-to-minute data and slower rate data from the EHR, that every minute we say sepsis, septic shock, just using standard consensus diagnostic criteria. We refer to these as the clinical labels. So at some point, if a patient is going to transition from sepsis to septic shock, they do, that's labeled time T2 here. The patient is in septic shock. Here the patient is in sepsis. the key assumption of our work is that we consider each of these clinical states to be divided into two substates. The first we will call the non-transitional state. The second we call the transitional state. The transitional state precedes, in this case, the transition. It's the state of sepsis, but it's what comes before septic shock. And so what I'm plotting here is time, and on this axis is a risk score. We're going to compute a risk score that is telling us about the state of this patient. That's plotted in the blue line. We're going to compare that risk score to a threshold. At some point we announce that patient is now in this transitional state. Our assumption here is that in sepsis, the physiology of the patient is obviously not normal. It's different. They have a bad infection. But at some point that physiology begins to change because they're going to transition into septic shock. Things are getting worse. And so that's what we call a transitional state. And our job is to see how early can we detect the transition into this transitional state. How do we characterize the transitional state? We know from the clinical labels when the patient is in septic shock. So we look at a time window 3 hours before that clinical definition, when the patient has not been described as being in septic shock, and we assume the statistical properties of the data we measure over that preceding time window reflect what's going on with this patient in this more serious condition. They're about to enter septic shock. So that's how we build a statistical model of the patient's data. We use a fixed threshold classifier strategy to build a predictor using these data. It operates on the risk score, and our goal is to use this statistical model to see how early we can predict the transition into the state. We don't care about predicting the transition into the state. We know the patient by this clinical definition is in sepsis shock. We want to make the determination that this patient is very likely to go into septic shock before they're classified as being in septic shock. So that's how we do it. Just to give some more details, currently we're doing this using a wonderful database of adult ICU subjects built up by Roger Marks at MIT and I think Beth Israel Hospital. And it's called MIMIC2. I already said that we use the Sepsis 3 consensus definition of septic shock. We're using generalized linear models to construct this risk score. We build an estimated probability that the patient is in septic shock. We choose a decision threshold on training data to optimize performance. And then we start at time 0 with the patient we've captured from the data and apply this decision rule to determine when we predict the patient is highly likely to go into septic shock. There's nothing novel here in the machine learning aspects, the classification strategy. We're using the well-known technique of generalized linear models. We chose them because it yields what we call interpretable decision rules. Here's the risk score. The vector X is a bunch of observed physiological variables. Here they are. And they just get weighted and summed together. And the weights tell us about the importance of that variable in the decision-making process. You can compute standard errors and statistical significance of coefficients. And that just helps us prune down the decision rule and can help give intuitive insight into how the decision is being made. So here's an example. Here's a patient who never transitioned into septic shock. Here is the optimally computed threshold from the training set. So we're applying this test data based on that classifier. The risk score never crosses threshold. We predict this patient isn't going to go into shock. Here's another example. There's the risk score computed minute to minute as physiological data come in. Compute that risk score. It crosses the detection threshold here. That's at 681 minutes into the data set. On the basis of the Sepsis 3 definition of septic shock, that transition occurs at minute 2076. That's a 23-hour lead time in advance of the clinical decision that this patient is in septic shock. These aren't cherry-picked examples. When we do this in large numbers, hundreds of patient examples, we obtain a sensitivity in this classifier of 87% and a specificity of 86%. And importantly, the lead time is 18 hours before, according to Sepsis 3, we say these patients had shock. And so this is a window of opportunity to do something, to intervene in this patient. I have a colleague, Peter Pronovost, who runs the Institute for Patient and Quality Care at Hopkins, the Armstrong Institute. And Peter uses this expression, and I love it. He calls the physiological data coming from patients ephemeral data. And he says that because virtually everywhere, these data are displayed on monitors and then they're gone. And these days, we often talk about collecting the genome of every patient and using that genomic information to predict something about the healthcare needs of that patient. And in my view, these are some of the most actionable data being collected, well, not being collected in a hospital, available in a hospital, but not currently being collected, that inform us about the physiological state of the patient right now. And I think they're highly actionable, and I think the frontier area of research is really to understand the nature of these data and how they can be leveraged to help critical care physicians make better decisions. They live in an information-dense world. Data is coming at them at an overwhelming rate, and they are very excited about the prospect of working with engineers to understand how to model and leverage these data. And so the first step in doing this, I think, is to build automated and scalable methods for data capture, things that are open source, things that other people can bring into their own institutions and use. This is what we're doing. And I'm showing you here an example of what we can now do. We can now pull, Hopkins is a GE shop. All the monitors are GE monitors. We can now pull any monitor in any bed at Johns Hopkins, ask the question, who's the patient? What waveform data are being collected? What numeric data are being collected? What alarms are being generated? And we can acquire that data for any patient. We can link that bed to the patient via the medical record number. And I think we have the basis here of automated, scalable, physiological data capture. And we're building an open source information framework to manage these data. So the data are coming from the patient bedside monitors. We're writing collectors that are specialized to particular monitor vendors. So GE, we'll be doing one for Philips, we'll be doing one for Motara. We'll make these available publicly. We grab these data, we real-time stream them into a time series database known as OpenTSDB, that's open source. The data are subsequently linked up with clinical data extracts from the EHR. We do that in I2B2. The data are linked between the waveform data and the numeric data are linked to the EHR data. We have a visualization front end that we call waveform, and we're going to explore the use of Galaxy as a way of delivering algorithms for analyzing this data in ways that leverage the reproducible research capabilities of Galaxy. And so I'm showing you this because it relates to what I'm now going to say about education. And everything I'm saying here, Dr. Pettigrew said really wonderfully in his very first presentation. I wanted to tell you about the Center for Bioengineering, Innovation, and Design at Hopkins, run by Yusuf Yazdi. This is Yusuf, that's his contact information if you're interested. Maybe 10 to 15 years ago, Murray Sachs, then the chair of Hopkins Biomedical Engineering, with Art Shukas and Larry Schramm, first put forth this notion at Hopkins of project-based design, longitudinal design team, we call it. And the idea was that we will create a course that students can choose to be in for all 4 of their undergraduate years. They will take on a significant design project. If they choose to, they can be in that same project as a sophomore, junior, and senior. The juniors and the seniors gain experience and they become the team leaders, and they mentor the freshmen and sophomores that are in that project, and it goes on and goes on. That's why it's called longitudinal design. The projects come from multiple sources. They come from clinical immersions where students go and be with the faculty doing research and come up with their own ideas. The ideas come directly from physicians in Johns Hopkins Medicine. They come from corporate sponsors, global health, corporate sponsors, med tech companies. And it's not just undergraduates. There's a master's program pursuing the same idea. It's about 15 months. The students start in the summer, and then they have 2 semesters. They do a US healthcare, and they do a global healthcare design project. It's really the same philosophy. It's been remarkably successful. Yusuf has done an incredible job at Hopkins. These students have gone off and started companies. They've won business competitions. They get millions of dollars in corporate sponsorship to do this. We ask students, why did you accept an offer from Hopkins BME? They say 2 things: the opportunity to do research and the opportunity to get on design team. It's very, very popular, and I think it teaches principles of lifelong learning that we were talking about in our prior discussion, because they have to solve this problem themselves. They write a business plan, and they understand the science and the medicine and the business aspects of the problem they're working on. So it's been tremendously successful, but I will point out a serious challenge to this kind of education. We do another course that's called Introduction to Computational Medicine. It's ongoing right now, in our 2nd year. It's a project-based course. Let me tell you that project-based courses are extremely faculty intensive. They require an awful lot. You've got to have lots of faculty and research staff and instructors. And unfortunately, when students graduate, you ask them, what do you regret about your Hopkins education? And many of them say, I couldn't get into design team. Because it's just not, we have 125 students coming in every year, and we literally don't have the person power to handle, to be sure that every student has the shot at getting onto a design team. They can't all do it. That's how labor intensive these things are. So it's something you've got to think about if you're thinking about project-based courses and design teams. They are very labor intensive. So I want to conclude by telling you about a new course that Sri, Sarma, and I are working on that's going to leverage this critical care physiological data acquisition that we can now do. This is a course that's going to be joint between biomedical engineering and anesthesiology, critical care medicine. At Hopkins, anesthesiology rules all of the ICUs. They manage all of the ICUs. And so with anesthesiology on board, this means that we can work with data from all of the ICUs. Our goal is to begin creating a repository of anonymized data captured from ICUs that is numeric and waveform data, the physiological data, are linked with electronic health record data. And we're going to use that as the core resource from which to build a project-based course. It's a year-long course, fall and spring semester. So over the summer, we'll set up the projects. We'll work with the anesthesiology faculty to define the projects. Maybe they'll use this data resource. Maybe the faculty will bring their own projects. But we'll set up the projects that will enable us to see what do we need to teach, what's the engineering and what's the medicine and what's the physiology and the biology we need to teach. And we'll arrange that over the summer. And then we'll go into the fall semester and start this. The course is going to be, you know, Hopkins is a split campus. We have a medical campus, we have an engineering campus. So the course is going to be taught at the medical campus. The students are going to go to the medical campus, and they're going to be there with physicians and fellows and residents, and these are super smart kids. So everybody is excited about mixing them up with these clinicians, with having these students in the clinical environment, and we'll use class time to deliver the right lecture material given the nature of the projects, engineering and physiology. And we'll use it to help students work on their projects. And it's going to go for a year. And it's going to be offered simultaneously at the undergraduate and graduate level. It's going to be part of our master's program in computational medicine, a core course in there. And we plan to spend a couple of years working out the challenges in doing this in the area of computational healthcare. And then our plan is to build out the same kind of project-based year-long course in the other areas of computational medicine that we focus on. We're very, and anesthesiology is very excited about doing this as well. So with that, I'll conclude. These are people working in the lab, and these are my faculty colleagues. Sri I've already mentioned, and Melabembia and Jim Fackler are the primary anesthesiology faculty working with us on the sepsis problem. Thank you all very much.
Very interesting presentation on real problems. Regarding the work of knowledge and within the burden of the patient, so the patient is beyond the knowledge. When you have additional information available, one of the ways that you have the changing of over time. And I would think that that's very features of field and knowledge. And the areas of our explanation is very different. And they're based on
I agree. I mean, obviously, in the presence of a cardiac infarct, the mechanics of the heart are going to be altered. That can be imaged using any number of techniques, such as spin tagging. And Natalia has developed electromechanical models. She has not yet leveraged those models in this application. She has restricted herself to static electrical models of the heart that don't incorporate mechanics. I agree with you. That could be another dimension of the problem that might help with the reliability of predictions made from the model. Even without, and we don't yet know how this is working in humans. I think one surgery has been done with one human subject at this point, and I don't know the outcome of that surgery. I don't know if the attempted site was the right site or not. That information will come in time. I think what the static models show, despite all of the other unknowns, the fact that we don't have the particular fiber structure of that patient's heart, the fact that we don't have the particular physiological behavior of that patient's heart, the physiology of myocytes, their electrical excitement is dramatically altered near in the infarct zone, and there's a lot of dead tissue in the infarct zone. In the border zone, the physiology of cells are very, very different. So none of that is tuned to the patient, and yet I find it very interesting that despite that we can't constrain those things, that just the geometric information alone appears sufficient, at least in the pig study, to guide these surgeries. And I do agree with your comment that motion is something that we can get. It is something that she can model, and there may be additional clues there that help refine these simulations. I agree with that.
Since we are just 40 minutes late, I suggest we have 10 minutes. Good. 10 minutes. Thank you.
That was really good. Thank you so much.
So what we're going to do is that we're just going to switch.
Yeah. Yeah.
Right?
That's okay.
And if there is already the adapter, you don't need actually.
That one works?
Yeah, but actually let's go on one.